So now we turn towards, I think, the next important piece. And I think, Dana, if you open up that document, I'll scan through it a little bit in talking points. So the state announced DESE and DPH working collaboratively, acting together. And actually, I was in a webinar with a joint meeting of the directors of the Department of Public Health and DESE today, where we looked together at the plan to move forward in the announcement that came out towards moving to at-home testing and a transition away from active test and stay at the classroom level and quarantine and contact tracing. So the direction of the state and following, as Connecticut has done and Vermont and New Hampshire also exploring, have moved to provide at-home test kits to all faculty and students to test once a week and then monitor for symptoms. And if they are symptomatic, they can also test with the nurse at school using the symptomatic-based testing. And the combination of those two maintain actively monitoring where we are while moving away from the contact tracing. And there's an interesting note there in their percentage that, you know, of all of the vast amounts of in-school test and stay and pooled testing, you have between a 0.7 and 1.5% of secondary transmission rate or picking up any type of positive tests. So you see, you know, 98% of the test and stay stuff you're pulling through is all negative. So is it a valuable monitor when the at-home test structure provides probably the same responsive capture window of positive cases? So again, you're widening your net by moving to an at-home test model because you're testing for both vaccinated and unvaccinated. It's open to all. So currently the test and stay is only for unvaccinated. It's not for vaccinated students. So it's leaving out of the pool a chunk of people who, again, might be indeed, you know, carrying COVID at a level at which it would detect it if they were self-testing. So you're expanding your pool of testing to include all vaccinated people as well if they opt in, and you're shifting some of your focus. Moving away from contact tracing, we remain able to use symptomatic-based testing. It's a requirement of being in the program. So you're not doing the whole class test and stay model, but if somebody is symptomatic, they can test on site and get a responsive data on the test to act appropriately. And then we move forward towards kind of a new structural set of tasks to maintain. I am applying to the state. There's a cycle of windows that open and close in terms of just how quickly you can move. If we apply by the end of this week, early next week, I think they gave me a date, we would receive testing materials for faculty as of the 24th, so they could begin the following week. And they're guaranteeing then the delivery of testing materials for students who opt in with delivery the week through the 31st. And once we receive those materials, you know, move them home to families that have selected to participate and begin the new model the following week. In so doing, the direction of the district is that after, on the day you receive your test materials, to rotate home to families, you end your contact tracing and quarantining structure. So until you're holding your materials and getting ready to shift them home into that testing model, you don't move out of your contact tracing or quarantining or test and stay framework. So there's no way to provide relief for our faculty, families, and people that feel the trajectory of the calling structure and the contact tracing, you know, has moved beyond its capacity to be meaningful for us or manageable. So there's two pieces there. You know, families getting 3 or 4 calls to say their child might be a close contact is, not garnering the attention from people that it should, and that now we need to move to the at-home model. So I have sent in the preliminary survey to say that we want to participate. Tomorrow, I plan to meet with the Superintendent's Advisory Committee, which is, again, that parent group that comes together to give advice and information and thoughts. I'll discuss this with them and hear their initial feedback. And then I'll start with faculty. We'll send them a form tomorrow allowing them to opt in, and then they would receive testing materials by the end of the week on the 24th. And at the same time, we would run a parallel model to make a form available to families to indicate an interest in participating. And it moves us forward. So first step is just to gather the data of interest and opting in, and from there, at the same time, in a parallel model, be able to continue conversations with people. I was in the meeting today, the director of the Board of Health attended as well, and I've updated Judy Noonan, head nurse, so we'll all start working together on just implementation and then a new FAQ to families. So those are the early kind of things that need to happen. It's a little bit of a fast-moving train, but that seems to be the methodology that's happened at each turn of these transitions. You can opt in later, but you have to stay in your current structure until then. So I think the first action is to apply. If you scroll down there, Daniel, and again, this document is available to you. So you can see here that they break it into a couple, which is you have to maintain, so we're the first column there. If we apply, you discontinue contact tracing and test and stay, you do symptomatic testing, you don't do individual contact tracing, you do weekly at-home tests with self-reporting, and you begin participation January 24th, and then students January 31st. So we'd have a model in place, heading into the first week in February. Questions?
So my question is, pretty much the system that we have in place will go away. And that, if I understand what was written up there and what you just said, is that all we have left in the school is symptomatic testing. So tell me how that works. I mean, the way I understand the phrase is simply somebody gets sick, and whether or not they came to school sick or not, based on the quote at-home testing. So the first opportunity that we have is that somehow or another they got sick with the symptoms of COVID. So do they report, say, to the nurse? Is that
So
they self-report to the nurse?
yeah, that's a great question. So typically, for example, currently, and I'll keep my phone close because sometimes Judy will text me her thoughts. Typically what happens is you do, like I've been helping with test and stay at a couple of the buildings in the morning. And typically in the time you might have a student who comes down who feels like they, are stuffy, or they might have a headache. And so they're little kids, oftentimes they might mention a symptom. And so the teacher then can send them down and say, why don't you go ahead and check them? The vast majority of our students aren't involved in test and stay. Again, that's going to be in targeted pockets. And you might have a classroom where you notice a little person seems to be coughing a lot, or they seem to be, sniffly. You'd say, you know what, why don't you go down to the nurse and they can check. So it gives you a monitoring structure, and it's one we're currently using now. Typically, most parents are working to keep their children home when they feel like they're demonstrating symptoms. You might have a student who, didn't particularly demonstrate them at home, but might be demonstrating them at school, or develops a sense of, not feeling well, and we pick it up. So it gives us a backup is really the goal of the symptomatic testing. We have had teachers who come down during the day to say, I felt fine when I got here, but I'm just not feeling well now. Can I do a check? So it gives you a backup structure, just another layer of mitigation. And then you might have students who aren't participating. So here's the other thing. You've got a strand of people who opt in, who will participate in the at-home testing, and if they come up positive, they report to us and they remain home. They become the reporting structure that we do weekly remains the same of the totals that we receive. Let's say somebody doesn't opt in and isn't doing a weekly test, you might have a triggered symptom that makes you test at school, and it gives you another layer of mitigation to pick up, those that might not be participating. I think the state's design is that they think that they'll have a healthy number of people that move quickly into accessing the testing and use it as a framework at their house, and other people who will add in over time, as they see the model working. So currently, I would say the nurses could give us a report, and I'd be happy to, of kind of like who they see during the day who gets sent down for a symptomatic-based test. But we've been running that parallel to the test and stay kind of the whole time.
Is the assumption that the students in school continue to wear masks?
So currently, across district, as you know, after lots of discussion, we are all currently masked, and the model right now for DESE basically remains that the anchor mitigating feature will continue to be masking. And then the option that will continue to run through that will be the off-boarding mechanism for districts as they get to still available options to apply for flex masking. I think most people anticipate will continue to be a framework that moves with us, with people applying when they feel like their numbers stabilize. So, we are already currently in a place where you have 2 schools who could do that, and that you're going to monitor it until you feel like it's a relevant conversation to have again, that they might move back into flex masking. The model, according to DESE, remains in place where any district at any time can still move to apply based upon their vaccination percentage to off-board, utilizing the same mechanism that we did for the other 2 schools. I would say, honestly, I think most districts are just in a holding pattern until they see the trajectory of, what they anticipate hopefully will be the peak and the decline of the numbers that we're seeing with Omicron.
So basically, not only is this, let's say, the new norm relative to what happens in school, but with the home testing and the availability of if you will, free test kits, it basically dismantles all the information that, let's say, the local Board of Health, or for that matter, the state's Board of Health, is going to have.
So interesting. I think that what they're finding is that they've already lost control of that because not everybody reports their at-home test. Yeah. So if somebody does an at-home test, they don't necessarily report it to DPH, then they call us. So during the holiday break as a sampling, I was running the contact tracing with the nurses, and while the nurses took a break, I was running that with the principals, and you would get an email or a call from a parent saying, my child, popped up at an at-home test positive, FYI, and so we would do the contact tracing loop. And then I was also getting information on a list of students from DPH, or from the Board of Health, where they had showed up in the system. So if somebody went and got a PCR or they reported to their physician, they would come through the queue in that way, which again is the Board of Health and the Department of Public Health mechanism. Our numbers will be reported to DESE, not to DPH. They will interface with each other, but our reporting system is such that the design of the model is that the at-home test gives us school-based data, lets us be responsive, and the Board of Health will see our numbers as we, share them in the chart as you see to DESE.
What's interesting is on the previous table that you put up there with 136 positive cases, that's a 3.5% ratio within the school system, which is pretty low for this period of time.
Yeah.
So I guess what's interesting here is that if you step back a little bit from what we just discussed, basically the country in this process is basically saying, well, if you're sick, get better. Because there isn't going to be a tool for which there's going to be a management capability at the state level, or for that matter, at the local level. It's basically go back to life as it was.
Yeah, I think.
To you to test.
Right, so there's a range of, there's a range of public health growth taking place. So when we look at the trajectory of public health, there's been times when you can check for a flu, but you have to go to your doctor and they check you for the flu and you find out, was it the flu I had? Oh, I did, you might not know, you might have been sick for 10 days, you might have really been ill and you think you had the flu or you did or you didn't, unless you go to your doctor and get a test. With COVID, what we've seen, and what's interesting in this is an aspect of public health that is now personalized with a home access, increased for the masses, giving us, people self-control to kind of do general diagnosis and then direct how, their severity of response, right? So I think it is an interesting evolution. I think, how Department of Public Health will gather that data will be interesting. I mean, you notice now, for example, they've also used the wastewater for their general benchmark, which I thought was a very, also kind of another way that they respond to, like, they track that number, which they feel, is a benchmark that gives them good data as well. So it's just an interesting evolution of understanding public health. The idea of, as we've talked about, many countries have always used masks much more flexibly than we did in the US, and now you see a change in norming. I think you'll see masking continue with flexibility for people. Like when I fly, I'll wear a mask, or going to doctor's offices, it'll probably become a norm. So, those are things that just become a change, and I think we're kind of in the middle of it. I would say it's interesting if I wasn't so tired of it, as we all are. It is fascinating. I think we'll look back on the trajectory, the evolution of the public health, and the question is whether or not they'll start to do more of that type of home-based checking so that families have better data around, keeping their child at home or going to daycare, or, just whether they're going to work at home that day or go to the office based upon what their at-home tests show. Like, I just think it's just going to be an evolution that'll be interesting.
Interesting.
Question?
Well, I listened to the Board of Health meeting last night. They seem to be recommending the testing at home program. I'm not sure that they knew that the contact tracing would end. It sounded like there was discussion about it appearing in other school districts across the state, but I'm not sure that they knew that it was part of this program to no longer contact trace within the school. But they seem to recommend it. And that they're meeting January 31st with only one agenda item to discuss their mask mandate for the town. And then they meet again on February 15th. Thought I would put it out there since this is our discussion about this program. It sounds like the next evolution for us. I am curious, are all school districts that apply for the program accepted into the program?
Yeah. Yes. And I think it'll be interesting to see. We'll get data starting tomorrow. I mean, I know that they'd already had people that had applied. And, it is the only mechanism by which DESE and DPH are providing an offboarding of the model that people are currently in. And so structurally, I think as people find they can't manage the volume or the sense of, again, purposefulness to the fact if 98% of the time you're pulling all negatives, and you're looking at the value of your time and energy and scope, you'd rather be able to actively do the on-the-ground nursing that's kept kids healthy and well, and the mental health interventions and the things that nursing does that keeps our population safe. Those things get displaced by test and stay. And so we have to make important values decisions. As you say, you look at our trajectory of numbers, where do we want to place the value of time and energy? So those are the pieces that will guide our next set of decisions. I think that, as I said, I'll meet tomorrow with the superintendent's advisory. I'll do the general applications. We'll let people give us options of interest for participation, and then we'll start putting together an FAQ.
Any other questions, comments?
Yeah, just a comment. As the severity of this literally goes down, out of 136, I'm wondering how many were even hospitalized or even see a side doctor. So we should consider where we are in the cycle and not, like you said, there are other aspects like mental health, which comes into focus now. I'm all for testing at home, you know. We are overdoing, yeah, I mean, my daughter is in high school and we get emails about contact and pretty much ignore it, you know, that's all.
Right, I mean, I think
We're
the.
at that stage now.
Yeah.
A year back, yeah, we would have freaked out.
Well, right, I think that the public health trust is based upon the information you're getting being relevant, right? And truthful and clear. So public health trust remains essential to the framework of being an open and busy society, and the messaging we send has to have relevance and clarity that people feel is weighted properly. So, you know, I think the way we're messaging and the way we're contact tracing doesn't match the weight of the impact when you're looking at 98% of them all being clear every day. So I think parents see that, I think students see that, and it merits a change from us.
And I think this just goes back, I know this was stated at the Board of Health meeting, but very little transmission happens in schools. Schools continue to be a very safe place for people to be, for adults and children to be. And I feel like the at-home testing can just add to that safety, meaning someone isn't feeling well and they wake up and maybe there is an adult at home by the time they leave for school. And so they get to school and maybe they're still sniffling and stuff. But if they can test at home right when they wake up, when the adult is still there, they don't have to come to school with the sniffles.
Right.
And be tested at school. So
Right.
I think it's smart of the state to, this is just another phase and evolution and how we learn how this works. And we've all learned to monitor our symptoms and we know what to
They
do.
indicated that this model is set to run through April 1st. April 1st or April 22nd, like guaranteed through April 22nd structurally and, you know, organizationally, at which point they want to let people know that part of this model is continual evolution and that it will be, you know, assessed again. And the other piece of that being that moving with the transitions such as these mean that we can draw from each other across districts and information and structurally. So I think the timing is right. I mean, again, we decided not to abandon contact tracing and test and stay when pretty much all our partner districts around us already have. And I think, you know, moving in this next directional phase will let us draw from each other as colleagues and just what their implementation is like, and give us some kind of data comparison and practice comparison. So, you know, that'll be part of process in the next week. And, you know, I'll probably call some people tomorrow just to check in on how quickly they're moving, that type of stuff, and I can keep you updated.
And we can contact trace if we want. Like if there's something pops up that's
There's no
strange,
rule
we can
against
do
it,
it if
right?
we
If we
want,
had a
but we don't
question
have-
about something
yeah.
and we felt
It's not
we needed to,
mandatory.
yeah.
Okay. All right, thank you.
All right,
Strongly
thanks.
recommended. Right, it says strongly recommended to discontinue contact tracing.
Yeah.
Yeah. And the test
It's
and
always
stay.
an option.
Right, right.
so, yeah. All right, thank you. Thank you for all that research. I know it's been a lot of information coming out. You spent some time on a webinar today, so I appreciate it. It's a lot to take in.